can tell you that actually our almost final estimate is to have ICU mortality around 40%. And this is more or less the hospital mortality. Actually, we have no cases, even of course we have the last 25 patients to see, but on 130. So I think we are almost near to the final data. Hopefully not to get new patients, of course. We should have hospital mortality of around towards 45%, because actually we have no patients died in the hospital after ICU. And I will tell you more or less what we did actually. So this is the first slide that I think everyone can see. Some slides were taken from a recent webinar. So it's also a thank from colleagues, Grasselli, Abreu, and Dr. Zhang from China, but they share my feelings. So COVID-19 was characterized by a significant mismatch between the number of patients requiring ICU and the available ICU beds. This was mainly in some regions. We had also some time in which we had a little bit in difficult, but we had some advantages because we had 10 days later. So we were able to prepare. And what we did was to create a network in the region between hospitals. I think this was very important, the network among hospitals. So we were continuously chatting, even now, of course, now is less hot, of course. And we could move patients from one ICU to another. Of course, we were the largest in the region. So, and second, we had to double the number of beds in the ICU. These were the two things we did. Network among hospital, and we had to double the beds in each hospital. As I told you, we increased for almost 30 beds to almost 60, 70 beds available. And in fact, the ICU capacity, I agree, should be increased as a network dedicated for COVID-19 ICU, as I told you, and this was, I think, very important. Of course, we know that health workers have to be trained on proper use for personal protective equipment. This was very important also for us. At the beginning, we started with a very complicated white dressing, as you know, completely covered. But then we decided to have a very light dressing. I tell you our experience, when we go to the patient, we have a sort of hat covering also the neck. Then we have glasses, a vision, and then we have FP2 plus a surgical mask, if available FP3. Then a hydro-repellent gown from surgery, then double coverage on the shoulders, but now we have boots so that they can be better cleaned, and 2 gloves. This is the equipment when we go to the patients. Otherwise, we always dress the FP2 and surgical mask and a normal gown when we are outside. And of course, the protocols. The second point was mainly for intubation. This again is from Professor Zhang from China, but I share with him these things. We had a team in our hospital, anesthesiologists. You know, our situation is a bit different, but we can say intensive care physician, we are also anesthesiologists, and we had, of course, a team that was going in the unit in the hospital for COVID patients, mainly infectious disease, and other unit when we collected all patients for non-invasive respiratory support or advanced support. And they went there and they intubated the patient when needed or delivered the non-invasive respiratory support. And we used always video laryngoscope, mainly for intubation, and of course under protection. So video laryngoscope was the technique of choice. This is just to tell you how we worked. We try to identify, we perform many CT scans, I can tell you. After the first 8 days, I can tell you after the first 3 days, what happened. The first case is, okay, we were a little bit stunned, okay? We did not know exactly what to cure because we had not get many informations at that time. This was on February 29, was the first intubation in Genoa. And the first intubation in Italy was on February 21. So it was just 8 days after the first intubation in Lombardia. We got this patient. We didn't know exactly what to do, very hypoxemic. We say, okay, just dressing was the main problem. We have to put the patient, we had freed all the beds, so we were ready to go. But what happened was the real story was that at the third day, unfortunately, we just started to admit one patient who looks to go quite good, suddenly died. And we did the echo that we're doing. We found a thrombus in the pulmonary. And this was on March 1. And this changed since the beginning the view of this disease. Now everyone is talking about vasculitis, thrombosis, but I can assure you, on March 1st, almost nobody knew what you were treating. And nobody reported, even the Chinese or anyone published anything on that. And this changed our view of the disease. Because we understood that this disease was not a pneumonia, was a pneumonia, but not a normal pneumonia, but was something more complex. And at that point, I decided to start with a CT scan to understand what was going on. So we did almost all CT scan in all patients during the course of the disease, a different people. We did a CT scan then, and I will tell you on angio CT to look at the pulmonary embolism. We started to do CT perfusion, and I tell you some very initial data that changed our view. We did CT scan at the discharge, so we changed completely, at least our view of the disease. So as you can see, more or less, this is not the final, it's just, I prepared just few slides. The first one is the typical, it's also called phenotype 1 now. Is a multiple focal with ground glass opacities, triangular with a sissuritis and peripheral. I can tell you, most of these we don't see in the ICU, very few of them, less than 20%. Then we can discuss if this is due because of the time of intubation or not, but we have seen very few patients on that. And interestingly, these patients, when we look at the CT perfusion, you can you have almost 50% aerated, 40% ground glass, 10% or less than atelectasis, very minor, some effusion, and these areas are over-perfused. A lot of perfusion in the ground glass and a lot of perfusion in the aerated area. So you have two effects, in my opinion. Shunt in the ground glass and low VQ in the aerated lung, because the aerated lung is over-perfused. These patients, usually we try to take, probably they keep more the non-invasive ventilation, then I'll show you what we did for that. They are better compliance, but as I told you, now we have to look at all the data, but from clinical experience, I think it's no more than 20%. In this patient, we were moderate in PEEP, 10, 12. We started with a bit higher, but we were moderate from 8, 10, 12 centimeter of water. In these patients, we also, of course, we used some nitric oxide. We used prone position if we were in trouble. But we found that in this patient, the improvement in oxygenation, and now we have data, was mainly due to a redistribution in perfusion. So in the phenotype 1, when PEEP was necessary or prone position was necessary, this was associated with an increase in PCO2 or mainly when we applied PEEP, mainly some little bit recruitment of this gray area, but mainly redistribution of perfusion. Then we had, and then non-invasive ventilation. We used this, mainly CPAP. I will show you later what we did. And we also used non-invasive ventilation in prone. And most of patients, they improved oxygenation in prone while doing non-invasive ventilation. However, we did 8 patients. We did the CT scan in supine and prone. Now we have to release all this data. But we found that the lung was decreased. So there was more non-aerated lung, but the oxygenation improved. So we believe that prone position during non-invasive ventilation improved oxygenation mainly for a redistribution of perfusion, not a redistribution of recruitment on sound. These at least are the 8 patients that we were able to do CT scans, supine and prone in spontaneous breathing. Then the phenotype 2 is a mix. You start to have problems, so you have to start more non-aerated lung, as you can see here, or poorly aerated lung. And this, the non-aerated, is asymmetrical. So you have on one side and not on the other. In this patient, we use the lateral position, we use recruitment, use prone position, use, of course, always nitric oxide. We use a little bit higher PEEP, but the compliance starts to decrease. And then you have what we call phenotype 3, which you see in this patient, we had almost 40 to 30% normally aerated lung, 40 to 50% poorly aerated lung, and 20% non-aerated lung, and some patients, a lot of non-aerated lung, and that we put in ECMO, I will tell you. And you see the hyperperfusion. We found that all these areas were hyperperfusion. So we found that the problem was the hyperperfusion in the lung. You have some hypoperfusion, but is minimal in the periphery. So also this question of thrombosis, I think we can have a major thrombosis, but the peripheral thrombosis, at least from our in vivo data from pulmonary perfusion, was not so heavy. We found more blood flow in the lung, more blood in the lung, not less blood in the lung. And now there are some areas in which you have a little bit less, but are not so relevant as compared to the amount of blood flow. So I think that the concept of microthrombosis has to be revisited. In this patient, we set PEEP according to driving pressure or to oxygenation. There was not much change, around 12 to 15. We used prone position and again nitric oxide and so on. As you see, we used a lot of nitric oxide, also for a very long period of time. We had patients even 15 days with nitric oxide. And so this was something that so we did. What about ECMO? ECMO, now actually we have 2 patients in ECMO. We reserved for very, very severe cases, or with patients with myocarditis. So with arteriovenous ECMO or veno-venous ECMO plus intra-aortic balloon. Now we see, because the final outcome of this patient, that of course they represented a minority. So this is more or less what we found at the CT. So mainly phenotype 2, phenotype 3, overperfusion. We have the effect of PEEP, not much effect of PEEP in terms of recruitment. And now we are trying to identify the pattern for those patients who improved or not in terms of prone position and in terms of nitric oxide. The second slide that I wanted to share is the following. This is what we did in the ward. So was our flow chart. So when you have the patient spontaneous breathing in air and SpO2 was lower than 92 and respiratory rate higher than 28 with dyspnea, at least one criteria, we started to give oxygen therapy. So with facial mask or Venturi mask at 40%. If there was an improvement, okay, the patient was kept in the ward. If there was no improvement, we started to use, if possible, high flow nasal cannulas, up to 45 liters per minute with FO2 up to 60%, with gone protection, with negative pressure. We had negative pressure in the infectious disease ward. If the patient did not improve, what we did was to start with CPAP or with non-invasive positive pressure. Mainly we use CPAP by helmet, I can tell you. Not positive pressure outside, but this is a matter of organization. At this point, if saturation was below 92 and respiratory rate below 28 with dyspnea, we intubated the patient. So we try not to keep the patient too long in non-invasive respiratory support. Or the patient improved in 10 hours, or we decided to intubate. Now we are looking at the CT scan of those patients intubated within the first 3 days and after the 3 days. But our feeling is that those patients that we admitted after 3 days of non-invasive respiratory support, they had a much worse CT scan, much worse CT scan. But this is, I can tell you, these are not final data. We have other data just from other centers that we are collaborating that show not much difference CT scan in patients treated with non-invasive ventilation or immediately intubated. So, however, what we did, we tried to avoid as much as possible as long as the long period of non-invasive respiratory support. When possible, of course, but when we are very pressed, of course, we have to buy time. So this was about non-invasive. And then we intubated patient according to what I said. So the second point that I think changed our view of the disease was the coagulation. You see here our protocol for coagulation. This is very important because we found that almost 20% they developed pulmonary embolism, and some probably microembolism, but pulmonary embolism is 15% and 20%. And what we found was that was better to have the risk of hemorrhage. We had 6 patients with hemorrhage, mainly on the psoas and sartorius muscles that we monitored by echo. Only there, psoas and sartorius. Very weak muscles, as you know, as a physiotherapist.
Yes.
Only there. And so all of them were treated, 2 by surgery and 4 by endovascular. And all of them survived, while patients who died more for thromboembolism. So we believe that it's better to have risk for hemorrhage than to have the risk for thromboembolism. But this was our experience. So as you see, we monitored the D-dimer, and when D-dimer was less than 1,000, we always gave prophylactic enoxaparin, which means Clexane, at 4,000. If the D-dimer was higher than 1,000 with no clinical events, we always perform, of course, in all patients, actually echocardiography, lung and heart. And if there was no right vertical impairment, we started to use therapeutic enoxaparin. So when D-dimer increased, we increased enoxaparin at 6,000 times 2, according to the renal function. If there was a right ventricle impairment, not related to PEEP, that was why we did not use in most patients PEEP higher than 15. In some patients we used, carefully monitoring the right ventricle. Of course, we escalated to our next stage, mainly to do angio. So if there was a right ventricle impairment, at the echo, we always perform CT angio. At this point, if we have a D-dimer higher than 1,000 and some clinical events suggesting embolism, if we have evidence of thrombus, clear thrombus, and the angiotac and echo, we started with thrombolysis. And then these patients were continued with coagulation with warfarin. If there was only right ventricle dysfunction, we started with heparin continuous at 25 units a day. And we monitored the coagulation with the activated factor 10 monitoring, that I think is very important, as well as TEG or ROTEM. We found a hypercoagulation of these patients. But you can move from hypercoagulation to hemorrhage. So this was our protocol is going to be published, and then we will publish all the data about coagulation stuff. But this, I think, was essential because many patients died not in our unit, but it's possible that many patients died during the pronation, for example, or weaning phase, or physiotherapy, so when you start to move, because the patient were not under coagulation. So this is very important when you start also not only control it, but also in the weaning phase. The other point that I like to show, this was from our physiotherapists, the third message, and not because here I know there are physiotherapists, physiotherapy changed our life in these patients, really changed. And this, I think, was a message that I tried to give. We sent some review now, and we have 2 studies specifically on physiotherapy in COVID-19 that are almost finished. This is just briefly, but we use, you see, many techniques. 2 techniques I like to mention, that the EZETA-PAP, that was very used in EZA-PAP, and we used aspiration, for example, at the extubation in the tube with the cuffing, the cuff, aspiration, removal of the tube, and aspiration in the upper airways, because these patients also required a loss of aspiration in the peripheral airways. And this is our extubation protocol. You see, what we did was that the patient was in pressure support at 8, PIP 6, FO2 35, good targets, and we always performed the air leak test. This was always performed in a chamber with negative. We moved the patient in our boxes, in most of cases, for extubation. If the air leak test was passed, we started the SPT trial with PSV at 0, PIP 6 for 30 minutes. And if it was okay, we extubated with this technique, so with aspiration in the tube, decuffing, and aspiration in the mouth. And then we immediately put a CPAP or non-invasive positive pressure support or high flow oxygen nasal therapy. If the air leak test was not passed, we use some corticosteroids. If a failure, of course, we were back to pressure support. We gave a rest period. Before extubation, we always give a rest period, and then we started again with a spontaneous breathing trial. So this was more or less our extubation protocol that we used in our patients, and I can tell you that we have no cases of reintubation except 1 patient. So no reintubation first. Second message, the physiotherapist carefully checked these patients for 2 days together with us. And then, and this I like to say, because this is, we are very proud of this. This, I think, was a very few centers, this experience. And that I would like to share with you. When the patient were extubated in the ICU, they stayed 2 days in the ICU, okay? Extubated with non-invasive, oxygen, CPAP, whatever. And then we moved in another unit just next to the ICU of 10 beds, where we used to monitor these patients as a sub-intensive care. And we found that at least 20%, 25% of these patients, after extubation, they have some problem in the Nemer, in oxygenation, and so on. But none of them need to be reintubated. So we were very cautious to discharge the patient directly from the ICU to the infectious disease. We maintained this patient from 3 days to 1 week in this special area of sub-intensive care next to the ICU. And the physiotherapists were fundamental in this area. So we are very proud of this, because we have no reintubation, only 1 patient actually, hopefully in the future. And all patients were not reintubated when discharged in the unit. So that's my message, is that the fight does not end at the time of extubation, but you have to continue to monitor these patients. I can tell you another thing, and I'm very happy to see Carmen so good here.
Me too.
Because we did the CT scan in all patients that we discharge from our unit to the sub-intensive care and sub-intensive care to the ward. Almost 80%. So we have a lot of CT scan. And all patients presented some alteration in the lung. And we did also the CT perfusion. And in this case, we found some area of hypoperfusion at the end of the story, not at the beginning. And second, we found in 35% of these patients discharged, they are almost perfectly well. from respiratory function, but there were areas of hyperperfusion again. So probably some activated area. And all of them, they have a negative swamp, deep negative swamp, because we don't believe anymore in the upper airway swamp, because we have more than one third of patients negative at the upper airways, nose and positive in the deep. So don't believe in the negative upper swamp. You need at least other 15 days. So now we have a quarantine of at least 30 days, because you can be infectious even with 2 negative swamps at 14 days. And then the neuromuscular, very important. Tracheostomy, we tracheostomized only 15% of our patients, and very late, after 14 days. Now we will have the final data, but I think no more than for 15%. And we did the first surgical and now percutaneous without any problem. So not much tracheostomy we did, and we did only after 14 days. And the other message was that neuromuscular. We have the suspect and now the proof that there is myositis. So there is inflammation in the muscles. And so neuromuscular alteration in many patients after discharge. So they need physiotherapy, respiratory physiotherapy, neuromuscular physiotherapy, a lot of monitoring in most of cases. And what about the brain? The brain, we had 2 cases of stroke that we documented, not related, just local thrombosis, no cases of hemorrhage. We did also magnetic resonance. We did the liquor in those patients who we did not awake, not many, but we found the coronavirus in some cases. We found the coronavirus in the liquor also. So there are some neuro, but much less as compared to the vascular side and the lung. What about the heart? We found 2 patients with myocarditis. 1 patient is now actually in ECMO for myocarditis and with cardiac effusion, but not so high as we believed. So less myocarditis, more embolism. What about the liver? Some alteration, mainly when we use antiviral, now much less, but not a major problem. What about kidney? The last, the kidney, we had almost 15%, no more than 20% on CRRT. So the renal function deteriorated a little bit, but we need only 20% CRT. These are just to give you our experience. So these are my last slide and my sort of summary. Just first one, because we have no our data suggested this was important to reduce the risk to go to the ICU. We use protective ventilation, of course, as I told you, but you use also non-invasive ventilation early for not a longer period of time, but we used, and we have our data now. We almost used 300 patients in non-invasive ventilation, and we intubated only 20%. 25%. So even if we used sometimes probably longer time non-invasive, we were able to save a lot of intubation with non-invasive ventilation. So I don't believe that non-invasive ventilation or CPAP, whatever, was bad. Probably in some patient was too long. I don't know. We will look at that. But for sure, we saved a lot of intubation. Coagulation was the third problem. So thrombosis, as I told you, but major thrombosis. Probably some peripheral, but we found that hyperperfusion, as I told you. And hemorrhage, but in a minority of the cases. And again, if you have an hemorrhage, all patients were saved. With thrombosis, some patients died. And the fourth message, big message, is monitoring and physiotherapy after extubation. The story does not end at the end of extubation. We have to continue to monitor this patient for at least 1 month, and now we have a follow-up program for 3 months, 6 months, and 1 year of all these patients. So overall, as you can see, different lung phenotypes, perhaps a different approach. This, to do the CT scan for us was essential. CT angio was very important to understand the embolism. I think, of course, not for everybody, but we hope that after our study will be published, CT perfusion should become a sort of, I'm not saying a standard of care, but something like that in this patient. Vascular side is very important, I told you, so coagulation protocols are essential to improve outcome of these patients. And monitoring was essential with echocardio, lung echo, but also CT with angio-CT and CT perfusion in specific patients. COVID-19, as I said, is a double killer, one after intubation, but is also after extubation. So that's why we believe that at least 1/3 of the patients in other circumstances, they had problems after extubation and when they were not accurately monitored. There are probably some long-term sequelae in some patients, not all of them, of course, but we have to monitor them. And more centers are looking at that. I just mentioned neuromonitoring. Essential role of physiotherapists, of course, all the team, nurses, consultants, everyone. But physiotherapists in this setting were really our very great friends, together with anesthesiologists, so intensive care physicians, nurses, and physiotherapists. They really made the difference in this setting altogether. And of course, other consultants, but these are the three leaders, I think, for COVID-19. And information, I think, helps. This is for authorities, was for a presentation for authorities, that we have to say to the people that this is a very bad disease, it's a very complex disease, it's a very difficult disease, people died. The ICU mortality we run, if you are lucky, around 50%, 40%. In the worst case, is 70, 80%. We have report from United States, we have report from France, we have report from UK, they have 67, 70%. So it's a terrible disease when we have to prevent early, I think, corticosteroids, immunosuppression, and anticoagulation. And so I am very feared about the less, we have more openings since tomorrow in Italy. We have less lockdown. We hope the best, because this was and it was a very terrible experience. But I want to finish with another message. It was also a extremely, from human point of view, exciting experience. I would never have to do in my life, but I want to see also no matter. Some people say no science, who cares? When we started to treat these patients, we did not know. We treated the unimaginable, the unknown, something that we did not know what it was. We have teams of people really, only for that, for hours and hours a day. This was unbelievable before. I think we learned that we have to have a territory medicine and hospital medicine together. For the healthcare system will be a challenge. A mix between patient-oriented, which is hospital, and population-oriented territory. We have to change the way and to give healthcare in our patients. So I think that was a terrible experience that will remain in my heart. For many reasons, I will never forget. But from this point of view, I think I get even more from this COVID-19. This was just some ideas, some feelings, really from my heart, from my experience till now, from COVID-19 in Liguria and Genoa with our team. Thank you. And open from all questions here.
Very good, Paolo. Okay. I have some